To the Kanski lecture series, and in this is chapter 11, glaucoma part 6, and in this part we are going to discuss about the normal tension glaucoma. So as you know that a glaucoma normal tension is basically giving us that IOP is uh, of the normal range, like it is less than 21 millimeter mercury, and there is a glaucoma, mean that there is a chronic progressive optic neuropathy, and there is no problem of the angles as well. So normal tension glaucoma, also referred as a low tension or normal pressure glaucoma, is usually regarded as a variant of POG. The distinction between the normal tension glaucoma and POG is based on epidemiologically derived range of normal IOP. So basically, you know that a normal IOP, which we considered, is about 21 millimeter mercury, but for some reasons that in the normal tension glaucoma patients, it is not normal. It is an arbitrary. So why? Because this is just the IOP is based on our perception of how the epidemiologically uh, people are normal in this IOP range. It is an arbitrary division that may not have a significant clinical value, though it is possible that a spectrum exists in which towards the normal tension glaucoma end, IOP independent factors are of increasing relative importance. So the writer is trying to say that there can be some other factors which are contributing to the glaucoma, but they are still under research. Depending on ethnic background, 30 to 65% of patients with open angle glaucoma may have IOP that is within normal range on initial assessment. So, normal tension glaucoma is characterized by IOP consistently equal to or less than 21 millimeter mercury on the diurnal testing. So, diurnal testing is very important. You monitor the IOP in both day and night. Signs of the optic nerve damage is a characteristic glaucomatous pattern. Visual field loss as damage progresses, consistent in pattern with the nerve appearance and open anterior chamber angle. No features of secondary glaucoma or non-glaucomatous cause for the neuropathy. So all other features of the open angle glaucoma just is that the IOP is within normal range. And so what is the pathogenesis? Any etiological factors distinct those in POG have not been conclusively determined, although various mechanisms have been postulated, including anomalies of the local and the systemic vascular function, structural optic nerve anomalies, and autoimmune diseases. So these are some of the factors that considered other than IOP, that there can be some factors like systemic factors, there can be optic nerve anomalies, there can be autoimmune disease. With the introduction of the wide separate CCT assessment, normal tension glaucoma in some patients can be explained by very low CCT. Overall CCT in patient with normal tension glaucoma is lower than in PO. A smaller proportion of normal tension patient have been found to have a marked nocturnal IOP spikes, sometimes only detected on testing in the supine position. So sometimes it is possible that a patient have a low CCT, because the low CCT will detect the IOP lower, and also that on a diurnal variation we should do the in a supine position, because IOP spikes occur in supine position. So, what are the risk factors for the normal tension glaucoma? Patient tends to be older than those with POC, though this may be due to delayed diagnosis. Gender, some studies have found a high prevalence in females. So, females are more having a normal tension glaucoma. Race, normal tension glaucoma occur more frequently in the people of a Japanese origin. Very important. Family history, the prevalence of POC is greater in families of patients with the normal tension glaucoma. Then in normal population, mutation in the OPTN gene coding for optineurin have been identified in some patients with normal tension glaucoma, though also in patients with POG. So OPTN gene is sometimes also implicated. CCT is lower in patient with antigen than in POG. So very important, CCT is lower. Then there is an abnormal vasoregulation, particularly migraine and Raynaud's phenomena has been found more commonly in NTG than POC by some investigators. However, others have found abnormalities just as commonly in POC. Systemic diseases associated with vascular risks such as diabetes, carotid insufficiency, hypertension, and hypercoagulability may be also important. Systemic hypotension, including nocturnal blood pressure dips of greater than 20%, particularly in those on oral hypotensive medication. The early manifest glaucoma treatment trial confirms that low blood pressure is a risk factor for the patient in NTG. So, not hypertension, hypotension is basically the risk factor for the POG because of the arterial BP and the IOP difference. The duration and magnitude of decrease in nocturnal blood pressure below the daytime means blood pressure predict progression in normal tension glaucoma. Obstructed sleep apnea syndrome may be associated perhaps by an effect on ocular perfusion. Autoantibody levels have been found to be higher in some groups of NTG patient by some investigator. Transluminal pressure gradient, the difference between the CSF and the IOP, this may be on average be larger than in POC. Ocular perfusion pressure may be relatively lower in POC. Myopia is associated with the greater likelihood of glaucoma and its progression. Thyroid may be more common. So these are all the risk factor for the normal tension glaucoma. So you can see that this is a 24-hour blood pressure chart showing a nocturnal dip. So uh, series 1 is showing and do series 2 is showing. So what is a differential diagnosis of a patient with normal tension glaucoma? So there can be angle closure should always be ruled out by meticulously dark room gonioscopy. Low CCT leading to underestimation of IOP. It is possible that a thin posterior ocular wall may increase the mechanical stress in the region of labina capriosa. Prior refractive surgery and a corneal ectasia may also lead to a relatively false low IOP reading. So LL closure and low CCT POG presenting with an apparently normal IOP because of the wide diurnal fluctuation. Plotting a diurnal IOP curve over an 8-hour period. Phasing during office hours may detect daytime elevation, but detection of a normal IOP spikes requires substantial resource commitment. Previous episodes of raised IOP may have occurred as a result of ocular trauma, uveitis, lower or systemic steroid therapy. Masking by systemic treatment such as an oral beta blocker commenced after glaucomatous damage has already been sustained. So you can see that these are all some of the differential diagnoses that a patient may have with a normal tension glaucoma. Spontaneously resolved pigmentary glaucoma. The typical examination features of pigmentary glaucoma tends to become less evident with increasing age. Myopia in some cases of POC may also spontaneously normalize over time. Progressive retinal nerve fiber defect not due to glaucoma, such as may occur in myopic degeneration and optic disc erosion. Congenital disc anomalies stimulating glaucomatous coupling, such as optic disc PET and coloboma. Neurological lesions, such as causing optic nerve or chiasmal compression, can produce visual field defect that may be misinterpreted as glaucomatous, and neuroimaging should be performed if there is any suspicion, particularly in a young patient. Previous anterior ischemic optic neuropathy, particularly secondary to temporal arteritis, may give rise to a disc appearance and visual field defect consistent with the glaucoma because it gives like an arcuate type defect. Non-arthritic IA ion often occurs in a crowded disc, and fellow eye should be examined for this. Previous retinal vascular occlusion should always be considered. Previous acute optic nerve insults such as hypovolemic or septicemic shock or head injury. Miscellaneous optic neuropathies include inflammatory, infiltrative, and drug-induced pathology will often be clinically obvious but occasionally masquerade as normal tension glaucoma. So these are all the differential diagnoses of the normal tension glaucoma. So what are the clinical features of the glaucoma? So this is a figure that is showing bilateral advanced glaucomatous damage. In a normal tension glaucoma, A is showing us the right and B is showing the left disc. So you can see that the cupping has been like almost 0.9 to 1. So history and examination are essentially the same as for POC, but specific point variants, like you can ask about history in the migraines and the Raynaud phenomena, episode of shock, any trauma like head injury or eye injury, headache and other neurological symptoms, intracranial lesion, medication, for example, systemic steroid and beta blocker, very important. IOP is usually in the high teens but may rarely be in low teens. In asymmetrical disease, the more damage discs typically correspond to the eye with a higher IOP. So optic nerve head. So there are some changes in the optic nerve head that is slightly distinguished from that of the POC. The optic nerve head tends to be larger on average than in normal tension glaucoma than in POC. The pattern of the coming is similar, but acquired optic disc pit and focal nerve fiber layer defects are more common. Peripapillary atrophic changes may be more prevalent. Slender hemorrhage on the disc margins are more frequent than in POG and are associated with greater likelihood of progression. These are often missed if the disc is not photographed or is examined without magnification. Pallor disproportionate to cupping should prompt a suspicion of an alternate diagnosis. So these are all the changes that occur in optic nerve head. The disc is tend to be larger. Cupping is having focal fiber layer defects are more common. There will be the peripupillary atrophic changes, sphincter hemorrhages, and pallor is more prevalent in a case of a normal tension glaucoma disc. So what will be the visual fields defects in this case of POC? Normal tension glaucoma. Visual field effects are in the same in the poke, although there is evidence that they will be closer to fixation, deeper, steeper, and more localized. Very important for the MCQs of point of view of line, that how the visual field effects are in the poke and normal tension glaucoma is different, because in normal tension glaucoma, the defects are like this is a defect, this is closer to fixation, it will be more deeper, more steeper, and more localized. In more of the half of the patient, field changes are non-progressive over a period of 5 years and more without treatment. However, perhaps because of the delayed diagnosis, patients tend to present with more advanced damage than in POG. A high level of suspicion for a deficit pattern suggesting a lesion posterior to the optic nerve is important. So, what are the investigations that you can do? Other investigation are for as for POG. Although in selected patients, the following can be considered: assessment of the systemic vascular risk factors. Blood pressure measurement can be used to calculate ocular perfusion pressure. 24 hours ambulatory monitoring should will exclude nocturnal systemic hypotension in selected patients. So you can also do the blood pressure monitoring in this case. Blood tests for other causes of the non-glaucomatous optic neuropathy, such as vitamin B12, red cell folate, full blood count, erythrocyte sedimentation rate, CRP. Troponal serological, including Lyme disease, serum angiotensin converting enzyme level, plasma protein electrophoresis, and auto antibodies screen. Basically, these are ruling out other causes of the optic neuropathy. Indication for the neuroimaging in a patient with NTG: loss of visual acuity out of proportionate to cupping, loss of color vision on Ishihara testing, visual field loss not consistent with the nerve, retinal nerve fiber layer dropout, pallor of a neuroretinal rim of the disease, rapid progression despite normal pressure progression. So these are the all the indication for the imaging in a normal tension glaucoma. Carotid duplex imaging, ocular blood flow assessment, for example laser flowmetry, may have a useful clinical potential. In a patient with a glaucoma, undertaken neuroimaging if there is a deterioration of a color vision or if the visual field defect is not consistent with the retinal nerve fiber layer loss. So how will you treat a patient with a normal tension glaucoma? As a large proportion of an untreated patient will not deteriorate, approximately 50% in 5 to 7 years. So basically, untreated normal tension glaucoma will usually not progress. Progression should be demonstrated after before commencing treatment in most cases. So what you do is, before you start the treatment, you always look for progression. Like, you just take the baseline investigation, you follow up the patient, and if there is a progression, then you start the treatment. Some cases of the normal tension glaucoma progresses more rapidly than other. Because further lowering of IOP is effective in reducing progression, treatment should be considered in patients with advanced glaucomatous damage, particularly if central vision is threatened and those with long life expectancy. Regular assessment include perimetry should be performed at 6 months monthly interval initially. Non-specific advice: patients should be encouraged to take regular exercise. Yoga exercise that involve headstand should be avoided. Medical treatment: prostaglandins are usually prescribed as an initial treatment. Brimonidine may have a neuroprotective effect in addition to the IOP rolling effect. So brimonidine is one of the alpha uh, 2 agonist, and it is basically also have a neuroprotective role. Topical beta blockers should be used in caution, particularly at bedtime, as they can systemically absorb and cause a significant dip in nocturnal blood pressure. Betoxolol is a beta blocker of choice in these circumstances. Laser trabeculoplasty, particularly SLT, is a reasonable option to achieve IOP targets. Surgery should be considered if progression occurred despite IOP in the low teens. Antimetabolite enhancement of the trabeculectomy is likely to be indicated in order to achieve a satisfactorily low IOP and to prevent IOP spikes. So, if the medical treatment is not working, then you can always go to the surgical therapy. Control of the systemic vascular disease such as diabetes, hypertension, hyperlipidemia may be important in order to optimize optic nerve perfusion. Systemic calcium channel blocker to address vasospasm have been advocated by some authorities. So, antihypotensive measure. Remember that hypotension is the risk factor in the normal tension glaucoma. So, antihypotensive measures are being important. If significant nocturnal dips in BP are detected, it may be necessary to reduce antihypertensive medication, especially taken at bedtime. Selected patient may be encouraged to increase their salted food intake in consultation with the patient cardiovascular physician. Effect of sleeping in a head up position. The IOP is higher in a flat position than in a 30-degree head up position. Although this effect differ between individual, patient with progressive disease should be encouraged to sleep in a head up position, as the mean IOP is 20% lower in this position than in flat position in at least third of the individual. Neuroprotective agents of proven benefit are not yet available. Memantine is used to retard neuronal death in some central nervous system disorder but has not been shown to be beneficial in glaucoma. Ginkgo biloba 40 milligram 3 times daily may confer some benefit in selected cases. So these are all the journal managements: antihypotensive measurement, sleeping in a head up posture, and a neuroprotective agent. So that's it for the glaucoma part 6. See you in the next lecture.